Hello everybody. Over the next 20 minutes we will discuss the role of whole body MRI in the assessment of malignant bone disease. Here are my disclosures. Metastatic disease to the bones is common in advanced breast and prostate cancers. But current tools lead to poor confidence in assigning clinical states and assessing therapy benefits in patients with suspected or known bone disease. So we are unable to accurately predict the presence of metastatic disease and its extent, and the late detection and volume underestimation can misguide the therapeutic approach. Let me show you an example. Here's a 55-year-old man with a locally advanced prostate cancer evaluated on a 3T SCIRA system with an in-bore biopsy. The guidelines state that he should have a bone and CT scan for staging, and what we see are two abnormalities on the bone scan, but no concordant abnormalities are detected on the CT scan. A number of questions now arise. Does he have bone metastases? Is this oligometastatic disease, that's to say less than 3 to 5 deposits on the bone and CT scan? Should he have prostate radiotherapy and long-term androgen deprivation therapy, which would be indicated for oligometastatic disease but not for polymetastatic disease? Should he have metastasis-directed therapies to these anatomical sites, given that this is unconfirmed metastatic disease? I don't think that you can answer those questions with those technologies, which is why he underwent a PSMA PET-CT and a whole body MRI. You can see the right acetabular lesion shows increased PSMA activity and is abnormal on the B800 image of the whole body MRI, indicating that this is a metastasis. The left eighth rib is also abnormal, showing similar features of metastatic disease. The PSMA PET also shows the presence of polymetastatic disease. So now the question is, do we go ahead and give this guy pelvic radiotherapy with metastasis-directed therapy to just two of these lesions, and do we just ignore all the rest? This is an important question, and something that we'll come back to later. And what's wrong with CT assessments when it comes to assessing therapy response? We know that RECIST criteria don't apply to metastatic bone disease because it's considered non-measurable. Progression can occur on CT and we don't even see it, which means there are lost opportunities for timely interventions, and sclerotic progression and sclerotic response are difficult to distinguish on CT because CT indicates the matrix interaction of tumor cells rather than showing the tumor cells themselves. Here is a patient I saw recently, an 86-year-old man with metastatic castration-resistant prostate cancer. You can see that on a clinical trial he was being treated with an immunotherapy, pembrolizumab, and a PARP inhibitor called olaparib. Now, you'll notice that his PSA was blinded because the therapy decisions had to be made on radiographic changes on conventional imaging, that's to say bone scans and CT scans. And you can see that over time he is stable on the RECIST criteria, yet he was progressing clinically. He developed a drug toxicity and was taken off the clinical trial, at which point a PSA was drawn and he was clearly progressing. So he was clinically progressing. He is progressing on MRI, but you did not see progression on the CT scans. So it is on this background that we will discuss whole body MRI for metastasis assessment. Whole body MRI evaluates both the bone and the soft tissue simultaneously. It is sensitive for tissue cellularity and cellular viability, has applications for disease detection and for therapy response. Multiple advantages include potential wide availability, easy to perform, requires no injections of radioisotopes, potentially is quantitative, and we will discuss this in a few minutes. Now we know that when we evaluate the bone marrow and correlate with diffusion signal, ADC values and fat fractions, we can nicely show that the cellularity is directly related to ADC in an inverse fashion. Cellularity correlates positively with signal intensity, and high cellularity correlates inversely with fat fractions. ADC values are also related to cellular viability. So as we kill cells, water would move more, and therefore the ADC would increase. Here is an example of a man receiving chemotherapy for hormone-sensitive prostate cancer, before and after 4 cycles of docetaxel. These are the segmented images of the disease volume before and after therapy, and what we can see is the histogram moves to the right side, indicating a cell kill phenomenon as displayed on this cartoon. It is also possible to classify voxels according to whether they represent viable tissue or dead tissue. So in this schematic, what we've done is we've colored the dead voxels as green, the voxels before treatment as red, and the yellow voxels are in between. So if we magnify the images, we can see the distribution of dead cells, alive cells, and dying cells, or areas that show no treatment effect, likely treatment effect, and highly likely to be having a treatment effect. And it becomes very obvious that there are areas of treatment resistance in the lumbar spine, for example, in the right ischium, and there are areas where there's been a very good therapy effect. Now, it is possible to use this technology to follow patients in time. So if we look at this particular patient, we can see that 95% of the voxels were considered alive before treatment. After 4 cycles of docetaxel, 24% of the voxels were in the alive range. Then you can see that at the end of treatment, that didn't change very much. This is 28% of voxels are showing high cellularity. After the therapy was stopped, you can see that the tumor bounces back and is throughout the body. So 82% of the voxels are now in the alive range. The patient had a new type of chemotherapy with very little effect. You can see there is some response after 3 cycles, but after 6 cycles this is completely reversed. The patient then went on to a hormonal therapy, and you can see how the patient responds a little bit. Now these areas of resistance that we have been able to observe serially are related to continuous Darwinian evolution and tumor resistance developments. Now it's possible to use the MRI to look at genetic mutations within the bone marrow. So if you take this particular patient, you can see high signal on the high B value image, low ADC. When this area was drilled, there was a BRCA mutation that was found. After olaparib, a drug that we've already talked about, a PARP inhibitor, you can see that the ADC value increases, but later on you can see that on the contralateral side we've got an area of high signal on the high B value image and a low ADC, and when this was drilled you can see that the BRCA mutation had reversed. So this illustrates in a very dynamic way Darwinian evolution. Now it's possible to use imaging and other biomarkers, such as biomarkers from circulating tumor DNA, immunohistochemistry, tumor markers in combination to pick different therapies, for example in breast cancer. And by using these markers and applying them serially, it is possible to titrate therapies over time depending on the response observed. So if a patient had a primary resistance, you would change early. If you had a patient who was responding to therapy, but you could pick up an early therapy resistance, you could bring in the next therapy at an earlier point. And you could repeat. So enabling the patient to have the right treatment at the right time for the right duration. And here's an example of applying that methodology to somebody with breast cancer. So you can see that in this particular patient, initially the patient was treated with just a hormonal therapies, and you can see a very modest response. Not much change in the viable treatment fraction, but you can see a very early relapse emerging. The patient switched to a second-line hormonal therapy, but again, a very modest response, but with the development of an adrenal metastasis here and right axillary lymph nodes which were coming back. So the patient was then switched to a chemotherapy, and then you see a dramatic response. Again, as we kept the patient on chemotherapy, you could see treatment resistance re-emerging with the development of metastatic liver disease, which, despite a change in therapy, then increased in volume. So this is a nice example of how we were able to use whole body MRI in somebody who has predominantly bone disease to try to titrate their therapy to keep them as well as possible for as long as possible. Prospective studies have also begun. Here's an example of a prospective study looking at 43 women with metastatic breast cancer with bone-only disease starting a new line of therapy. Women had 12 weekly follow-ups with CT scans, MRI scans, clinical visits and blood tests. CT scans and MRI scans were independently read. The endpoint was the test that showed definitive progression requiring a therapy change. 29 patients at the end of the study had developed progressive disease requiring a therapy change, meeting the primary endpoint. And at that endpoint, we noted that 2/3 of the people progressed on the whole body MRI alone, 1/3 progressed both on the CT scans and on the whole body MRI simultaneously, but no patients had progressed on the CT scan. In fact, when we knew the patient were progressing and we repeated the bone scan at that point, only 50% of women were progressing on the bone scan. Let me show you an example. So here's a patient over about 18 months. She develops progression, and you can see that in the pelvic bone marrow. Here are the high B value 900 images showing the obvious progression. If we look at the CT at the same time, we can see there's very subtle changes, but this was not called progression prospectively. And here are the bone scans, and this is the bone scan report saying disease extent unchanged with no increase or decrease in the volume of lesions. I think I would agree with these reporting findings. So what do we need to do to develop whole body MRI in precision oncology? Clearly we need to standardize the imaging so that it's compliant with international standards. We need to develop quantitative biomarkers such as the ones I've already shown you from histograms, for example. We need precision estimates of these biomarkers. More biological validation is required. And then we need to do prospective clinical studies that show the impact of whole body MRI in patients. Now, Siemens have done a number of developments in this area, including the wholebody dot engine, which allows consistent follow-up of patients and for serial response assessments. One of the technologies that's been introduced is the iShim, which enables distortion-free whole body MRI. The Siemens system gives a very homogeneous signal from the entire body. This spinning MIP image is from a patient with neurofibromatosis. Furthermore, software has been developed using the Singavia Frontier prototype to develop experimental software, which has now gone into a VIA product. But clearly there's a need for better evidence on the clinical impacts for the next generation of imaging because of the consequences of stage migration. And this is really the elephant in the room. So what is a stage migration? Well, we know that oligometastatic disease and polymetastatic disease is defined by bone and CT criteria. And here we're talking about microscopic metastatic disease defined by next generation imaging. And this results in what's called the Will-Rogers effect. So the Will-Rogers phenomenon is related to reclassification of patients with next generation imaging. So for example, with conventional imaging, when we say the patients don't have metastatic disease, in that group are people without metastases and people with microscopic metastases. And when we say patients have metastatic disease, they usually have polymetastatic disease. And because the burden of metastatic disease is different between the two groups, these will be the corresponding survival curves. When we apply next generation imaging, these patients with microscopic metastatic disease will move into this group, and this false positive will move into this group. So we have increased the prevalence of metastatic disease by moving microscopic metastatic disease to this group. Interestingly, because the metastatic group now has microscopic disease and polymetastatic disease, they in fact will survive better. And this is now a purer group of non-metastatic disease, so they will also survive better. In other words, next generation imaging will increase the prevalence of metastatic disease, but will improve the outcome for all groups. However, cancer-specific survival for everybody in this group will not be increased because it's treatment and not imaging that saves lives and improves outcomes. So to improve survival, it's important to combine next generation imaging with stage or site-specific therapy. Here is an example of a study when 54 men with oligometastatic disease defined on conventional imaging were treated with stereotactic radiotherapy or observations. People treated with stereotactic radiotherapy had a better progression-free survival than these 18 men who were on observation, and this was statistically significant. When you dig down into the data, one of the most interesting results that came through was that SBRT had the greatest benefit for men who had no untreated lesions on PSMA PET CT scans, and that's the survival curve. So although this is the overall survival curve, you can see that the survival curve was better if there were no untreated lesions. So here are my take-home points. Whole body MRI will replace the current indirect, ineffective, in fact wasteful methods of oncological assessments of the bone marrow using bone scans and CT scans. There is a potential to alter diagnostic thinking when assessing therapy response because we can now positively assess the success of therapies, not just the disbenefit of therapy. We could help deliver the promise of precision oncology in patients with malignant bone disease when we combine next generation imaging with the new generation of therapies. And lastly, maturing acquisition and analysis tools now allow us to begin our validation and qualification steps for whole body MRI in patients with malignant bone disease. Thank you very much for listening.